Welcome to the Health Workforce Technical Assistance Center's webinar series. This presentation is entitled Rapid Cycle Quality Improvement. What do HRSA project officers and staff need to know? And it was presented by Amanda Norton and moderated by Gene Moore on May 19th, 2015. But before we get started, I would like to introduce to you today's speaker and moderator. Today's presenter is Amanda Norton. Amanda is a quality improvement consultant who has been working in the field for over 10 years. And today's moderator is Dr. Gene Moore. Dr. Moore is the director of the New York Center for Health Workforce Studies. Also, when the event ends, you'll be directed to the Learning Portal website, where you will need to sign in and answer a few questions to receive credit for taking this course. Amanda?
Great. Thanks so much, David, and thank you so much for having me here today. I'm excited to have the opportunity to talk to you a little bit about the use of rapid cycle quality improvement and how it will apply as HRSA project officers. So we're going to dive right in. We have a lot that we're going to cover. I just want to reinforce what David said. If at any point you have a question, please feel free to chat it in right away. If it requires me to kind of stop and clarify something, I will do so. Otherwise, we'll hold questions to kind of points throughout the presentation. So let's talk a little bit about quality improvement. And, I think to me, before we dive too much into what is rapid cycle quality improvement, I'd like to talk about what I see or what have been shown to be the key elements of quality, and that is the will, the ideas, and the execution. And I bring each of these up because I think they are a very delicate balance. The will to actually do what it takes to change and improve a system. The ideas, so often we're filled with ideas. But we need really strong ideas that we have confidence are going to be improving the system of care that we each are working on. And then the execution. So sometimes we're really strong in ideas, but our execution is poor, or our will, our passion is very strong, but we don't have quite the right ideas. And so I think I see this as a very delicate balance that I think we should acknowledge before we dive too far into quality. And when we say rapid cycle quality improvement, some of you may be thinking, well, quality improvement, what is that? Or this has been around forever. I've been doing quality improvement. This is kind of old hat. So some of you may feel very connected to quality improvement or maybe doing it intuitively and not even realize it. And so have you heard of some of these different models, total quality management, continuous quality improvement, Lean Six Sigma, or Six Sigma DMAIC and Lean, or the model for improvement? And I bring each of these up because from my perspective, I would call them a horse of a different color. And so they are based in and rooted in very similar theories and foundational knowledge. And, there are a few different founders of each of those theories, but the approach, the lens is very similar. And so if you feel very confident in some of those, I will say that this is going to feel comfortable to you. It will feel like something you've been doing for quite a while. But what we're going to talk about today is primarily the model for improvement, which is really the core focus of rapid cycle quality improvement. And the model for improvement is based off of Deming's work. And so he has a system of profound knowledge. It's really the foundation of much of his work. And it calls for anybody to really appreciate a system and view an organization in terms of the many internal and external interrelated connections and interactions. And so sometimes we look at what we do in a very siloed approach or a very specific and discrete independent approach. And in doing so, we kind of miss the system of profound knowledge. But we know that if we are consciously aware of and influencing the connections and interactions in these systems, we are able to accomplish a shared aim. And because it's called rapid cycle quality improvement, we also know that if we use this specific approach, we're able to accomplish that shared aim in a much more rapid or expedited fashion. So Deming's system of profound knowledge really acknowledges the psychology of change, the appreciation of the system, the theory of variation, so that variation exists, and the theory of knowledge. Now, we're not going to dive really too much into this today, but I cede it to you as a foundational concept of something that really matters when we consider quality improvement, because you may have heard of some of these terms we're going to talk about, but quality improvement is rooted in this understanding of the system of profound knowledge. So let's set the context a little bit for today. We're going to talk about rapid cycle quality improvement because many, if not all, of the FOAs that have recently been released in your departments have a requirement of grantees to apply quality improvement in some specific capacity. And so I've read through each of these FOAs, and I'm really going to be talking about rapid cycle quality improvement as you should be expecting your grantees, those who are applying for your FOAs, to be applying it to their work. And then we're going to have further conversations about, well, what does that mean for yourself as a project officer? So how can you support and engage your grantees in the application of quality improvement? And how can you as project officers continue to leverage that knowledge so that your grantees are able to really accomplish the best possible outcomes during the FOA time period? I do want to begin this conversation by just making a distinction between quality improvement and quality assurance. So we are going to stay very focused today on quality improvement. And so I'm going to highlight it in yellow because it is the crutch to everything we're going to talk about. And quality improvement is systems focused, as we just talked about. It acknowledges that there is fallibility in the systems we do. Teamwork is the core element of it, and errors are seen as opportunities. They are not punished. This is different than quality assurance, and many of us, when we think quality assurance, because quality is rooted in a history of quality assurance, quality improvement is. Quality assurance is often individually focused. It is focused on this myth of perfection, that there is a perfect way to get the system. We often are punishing a solo practitioner, and errors are punished. So if data is reported poorly, there is consequences for that, and that's kind of the quality assurance mentality. And so in today's conversation and what I'm getting the sense your FOAs are asking for, it really is looking at this improvement focus rather than an assurance focus. And I think of this quote to myself often, actually. Every system is perfectly designed to get the results that it gets. And so as you're thinking about your role as a project officer and the interactions and the work that you're asking your multiple grantees to embark on, remind yourself that every system is perfectly designed to get the results that it gets. And that means that when we're looking for opportunities for improvement, we're looking at that system, because whatever the result currently is, if it is that we don't have enough trained nurse practitioners, if it's that we don't have a strong enough geriatric workforce, our system is perfectly designed to get those results. And we're asking your grantees, and the FOAs are asking them to really redesign those systems to accomplish better results. So this is the model for improvement. It is based on 3 very simple core questions. What is it that we are trying to accomplish? How will we know a change is an improvement? And what changes can we make that will result in improvement? We're going to work through each of these questions today and show a few examples as well. So let's start with what are we trying to accomplish? And this is often referred to as an aim statement. And an aim statement is your ability or your grantee's ability to set forth specifically what it is they want to accomplish. And to be specific, they have to be saying what kind of improvement, for whom, who's the target population, by when, what is the achievable date at which this will be accomplished, acknowledging that this work doesn't go on forever. It goes on in different iterations and different phases, but you give yourself a timeline, and how much improvement. So aim statements are always measurable. So to some regards, they will feel very similar to SMART goals or SMART objectives. And in all honesty, they are one and the same. So if you are more comfortable with creating SMART goals or SMART objectives, creating an aim statement is exactly the same thing. It is the specific and measurable part of the SMART goal that gives the strength to the aim statement, because without this specific measurable amount of improvement you're trying to accomplish, an aim statement is no different than kind of a lofty goal, and we never know if we've accomplished it. And so an aim statement is meant to be your end spot. Where is it that you want to be in, say, 2 years? After all of this hard work, how will you know you've accomplished something? So the measurable part is critical in order to making these effective. But aim statements also really need clear, well-established definitions. So when you're defining exactly who is your target population? Is it all potential graduates of a nurse practitioner program? Is it a specific level of that program? Is it all, future dental hygienist programs or program participants? So really identifying who is your specific target population. And what do the terms and the measures within your aim statement mean? And how might somebody be confused by them? So if the aim statement is in any way confusing, you will find out very quickly that you're going to lose focus as a group. And so your grantees, sometimes, you know, I imagine as program officers, you've worked with grantees and felt like they were a little bit all over the place. And sometimes it's the lack of an aim statement or a really clear SMART objective that ends up with grantees, and it kind of feels like they're just grabbing at straws doing their work because they're not focused. They don't have that laser definition of what it is they're trying to accomplish. So let's think of a few examples that would matter to some of the FOAs that I reviewed. And so if we were looking at the Advanced Nursing Education FOA, you know, a grantee may submit an aim statement that says, you know, by June 2016, this particular university is going to ensure that 100% of their clinical preceptors are prepared to facilitate a positive clinical experience for students. And in doing that, all preceptors will undergo an annual clinical competency evaluation, and they're going to score at least 90% competency in these 4 domains. And so this is very clear. We know exactly what this university is trying to accomplish. And what they're trying to accomplish is focused on their preceptors. The focus here is the target population is not students necessarily. It is very laser focused on the competence of their preceptors and in very specific areas where they feel like they need to improve or their preceptors need to have the greatest strength. And so if I was working with this particular group of grantees, I would know immediately as a project officer what it is they were trying to accomplish. Let's look at another example, and this one comes out of the geriatric workforce example. And so if we were looking at that FOA, a grantee may submit an aim statement that said by June 2017, we're going to improve primary care engagement in the early identification of Alzheimer's disease and related dementias so that at least 90% of our patients age 75 years or older are assessed for Alzheimer's disease or related dementia at least once a year, and 90% or more of those who are identified to have Alzheimer's disease or related dementia, that some education is given and provided directly to the primary caregiver. And so this aligns very strategically with what is set forth in your FOA that one of the main core focus areas that a grantee may choose to work on. But then it dives down a little bit deeper and says specifically, how are you going to accomplish improvement in there? So this grantee is saying, we're going to make sure we're actually assessing patients who may be at risk, and those who are at risk, we're going to do some very specific education with the family and the primary caregiver. An aim statement is a simple and powerful tool, and so it gives you these concentric circles are purposeful because aims happen at multiple levels, and so you may find that your grantees or if you have a larger kind of regional application, they may each have different aim statements at each of these levels. And then there's this kind of larger aim that is situated in the FOA. What is it that you are hoping all of your grantees are able to accomplish so that you can identify the market improvement that comes out of this particular funding opportunity? So we're going to pause at this point and see, does anybody have any questions? I don't see any questions in the chat box. Let's just take a second to feel free to chat in some questions right now. I see we've had a lot of participants joining in the last few minutes, but any questions at this given point?
Amanda, this is Jean. I have a few questions. First, how is an aim statement different than a goal?
Okay. So, Jean, an aim statement, the critical difference is goals are often written as lofty projections of an improved state. And I often call them kind of pie in the sky. So they're very big statements, and they're not measurable, and they're often not immediately achievable. And so an aim statement is different because it gives you a definitive time frame, and it says specifically what is the piece of improvement we're trying to achieve. So a goal may say, we want improved care for all older adults so that everybody gets, you know, the care they deserve. Well, yeah, we want that to happen. Your aim statement is going to say specifically, how are you going to try to accomplish that?
Another question. Can you change your aim statement once you start working?
Yeah, so that's a really good question, Jane. Jean, sorry, I called you Jane. The aim statement, sometimes people feel really tied to creating these. almost like they're a strategic plan. So we spent all this time creating our aim statement, and so now once it's written down, we've almost written it in stone and we can never change it. But the truth of an aim statement, it is very changeable. And so if your grantees, or even as project officers, if you sit down and identify a specific aim, get working and realize this is not actually what we need to accomplish in order to meet our objectives, then yeah, you tweak your aim as you learn. So quality improvement is very much about experiential learning. So as you gain the experience, you gain the confidence that maybe your aim statement was a little off, you tweak it so that it aligns with what you truly need to accomplish.
Last question. How engaged should leadership be in setting an aim statement?
Yeah, another really good question. So leadership is critical to a good aim statement. And so if leadership is not engaged in the establishment of an aim statement, sometimes what happens is improvement teams spend a lot of time working on something that's just not critically important to an organization or a healthcare system. And when that happens, they really run into a lot of barriers and obstacles to being able to accomplish what they need to. So the resources aren't often diverted to the specific aim or effort. The team finds themselves often feeling like they're kind of banging their head against the wall because it's not mission critical. It's not, the leadership doesn't see this as part of the vision or the future in the next few years. And so whenever a team is establishing an aim statement, it is really critical to get the leadership engagement and understanding of both what it is you feel like you need to accomplish in, say, the next few years, and their perspective on what that means for the organization more generally or broadly. Great. Well, if there aren't any other questions, I think we will dive into the second question of the model for improvement, and this is how will we know if a change is an improvement? And to be really frank with you, this question is most focused on when it comes to quality improvement, and sometimes quality improvement is simultaneously tied to data. And yes, data collection is critically important to quality improvement, but it is not quality improvement in itself. And so when you're embarking in quality improvement, it's about changing, improving the care provided. And in order to do that, you must change the system. You must do something inherently different. It is not about measurement. However, we have no idea if that change is truly effective without measurement. And so quality improvement asks you to kind of take a step back and say, is this really working? For a long time, in all fields, but especially in healthcare, we have spent many, many years thinking that our hard work and diligence must intuitively be leading to improved results. And many of us can take a step back and look at our healthcare system and realize that's not necessarily what has happened. So we still have lots of opportunities for improvement in our healthcare system. So this model for improvement and rapid cycle quality improvement makes you kind of check those assumptions. But measurement for quality improvement is always about learning. It's not about judgment. And this is something that grantees and the healthcare workforce in general feels a little uncomfortable with, because we're used to measurement and data being for judgment, being for, you know, the ability to cut jobs, to lose resources if you don't meet specific markers. But in quality improvement, it's about learning. Where's my system not as strong as it should be, and what can I do to make it better? In quality improvement, the measures have limitations. They don't negate their value, and we don't spend an unduly cumbersome amount of time trying to remove those limitations. We just acknowledge them, because measurement and quality improvement should be the voice of the system. It wants to keep you in touch with what's happening so that as you're changing your system, as you're really trying to accomplish that aim, you're very closely monitoring if that is truly working. And they tell a story. They give you a reference point. I put this chart up here because, in general, it's just one of my favorite resources. It comes from a wonderful article, which it looks as though the resource is not showing up at the bottom, but we can make sure you have access to it. But Performance Measurement in 3 Worlds. And this shows some of the distinction between measurement and quality improvement, measurement for accountability, so when we were talking about quality assurance earlier, and measurement for research. And when we look across this chart, we won't go through each column, but in quality improvement, the aim, the purpose of the work is always to improve care. Within accountability, the aim, the purpose of the work is to compare, reassure, or spur change. So the focus is different. And it is even more different in research where the focus is new knowledge. How can we get new information? So when I said aim statements can change in quality improvement, it's because your aim is to improve care. And if what you're doing is not improving care, you change your aim until you get to a point where you can improve care. In quality improvement, we are testing. We are working to make some decisions about whether or not these ideas are effective, but they're not blinded or controlled tests. They are real-time, in the moment. Let's try this out. We accept some sort of stable bias, and we are not designing to eliminate it. And so if we continue to look through these different categories, what we will acknowledge is that quality improvement has a very specific home, and so it is not replacing research. It's not replacing quality assurance efforts or accountability efforts, but it has a different and unique piece of this kind of puzzle to improving healthcare. But the measures are always going to be just a little bit different. We're looking to look at the data more frequently. We're collecting samples, and we're not getting data just in case. In quality improvement, we look primarily at 3 to 4 types of measures. So outcome measures, process measures, balancing measures, and activity measures. And so outcome measures are those things that say, did we or did we not improve care? They're always focused on the population at hand. Who will be better off because of our hard work? Process measures, on the other hand, are more specifically designed to think about how will we know that we are doing this as often or as frequently as we could. So it's looking at yourself internally. How many people are coming through our geriatric program? How many nurse practitioners are graduating? Now, these are part of your process, but they're not inherently your outcome. Your balancing measures is really getting at, are we robbing Peter to pay Paul? So is there a negative side effect to this work that we weren't necessarily considering? Sometimes you'll see cost measures listed as balancing measures, and sometimes you'll see cost measures listed as outcome measures. But the truth is that sometimes what we do, there is just a flip side to that coin. And so having a balancing measure is just looking at the entire system and the impact of this change, this idea on that whole system. Activity measures are where we're often most comfortable. So what did you do? How much activity did you produce? Quality improvement is trying very hard to, we usually are very confident. So we have a lot of activity measures and a low focus on outcome measures. Quality improvement is asking you to flip that approach. And so really focus on the outcomes, and the activity is going to follow, but it is not the core component of your work. So if we were to take a closer look at what might some process and outcome measures be, these are taken directly from some of the FOAs that you currently, well, they're all closed now, but you recently had out. And so some of the process measures I saw in those FOAs, oh, I'm sorry, we're not into the examples yet. If we look at them a little bit closer, process measures are data collected, it is time limited, they are within your control, so in organizations, the healthcare systems, or even you as project officers control. They're linked to the specific ideas you're trying, and there are means to the ends. They're not the ends itself. Where outcome measures, as we said, are always patient and family focused. They reflect how care is experienced differently by a patient or family. They sometimes take a while to move the marker, so they don't always move quickly. And they're almost always at least one of them in your aim statement. So when we said that your aim needed to be measurable and specific, that means an outcome measure should be in it. Measurement and quality improvement asks you to have a balanced set. And so by a balanced set, I mean a few outcome measures, a few process measures, at least one balancing measure, so that you can look across the system of your change and really have a sense of whether or not it's working. It doesn't mean just have 2 outcome measures and nothing else, or 10 process measures and nothing else. It's a balanced system. You're using these measures to guide your improvement as you try ideas. And again, it comes back to this idea that not everything that we do is an improvement. Actually, most of the statistics will say that 50% of the things that we try, the ideas that we try, are in fact not improvements to the system we try them in. Now, that could be because of how we tried them or the idea itself, but that is the truth of quality improvement. And so this is asking you to be really conscious of your time and effort to make sure that what you do is truly an improvement. Now, we all have plenty to do, so we don't need to be adding ideas to our system that don't get results. And measures in quality improvement need to be integrated into a daily routine. So this is not the kind of data that you're waiting for a statistician to come and analyze for you. You're not waiting for an evaluator or a researcher to come and collect the data for you. You're able to collect this often and for yourself. So what are we going to do with our data? This is kind of the mantra of quality improvement measurement. You can't fatten a cow by weighing it. This is the truth. So we can't just continue to collect data on systems and expect anything to change if we're not truly changing the system. Some examples of process and outcome measures from your FOAs, and I kind of dove into this slide a little bit earlier. As I looked through your FOAs, you had process measures listed as the number of students trained, the number who graduate, the number of clinical sites that are engaged, the number of training programs within a particular grantee. And some of the outcome measures you had already listed in your FOA are the number of graduates who pursue specific careers, so kind of changing the career path of your graduates, the quality of care that is being provided by your graduates, and the cost of care that's being provided by trainees and faculty. So you're already beginning to look at this. I would say the key takeaway is that your grantees are understanding kind of the balance of both process and outcome measures and the ability to use that data. So a lot of times, actually in every healthcare system I've ever worked with, they're being asked to collect and report enormous quantities of data. One of the core differences of quality improvement is that the collection of data is only the first step. We want everybody to be using that data. It's not just to be given to somebody else in hopes that they wanted it and they're doing something with it. You want the data as a grantee. You're going to be using it to identify what you're going to do next. And this is a point that is often missed. I've had the great privilege of working with hundreds of healthcare systems, and we don't often think of our data as a resource. We just think of it as a burden, as a requirement, as something that somebody else is making us or forcing us to do. Part of that is because we put our data in gigantic spreadsheets, and it is not very usable in that particular fashion. And so quality improvement pushes you to use the data in the sense of display it, graph it, let's see it. So it matters how you display your data, and I think I'm kind of preaching to the choir here, but this is a point that I can't resist making. And so if we are to look at, right now we're looking at aggregate versus time-ordered data. And so what we're looking at right now is time-ordered data. And in looking at this, we see that this is a particular intervention around decreasing mortality. And in decreasing mortality, we started up, we had about 8% mortality. We were seeing some really nice declines. Then we start an intervention, and we see some actually pretty significant increases again in mortality. Now, in looking at this data over time and continuously, we realized that our intervention actually didn't seem to be impactful. In fact, it seemed to turn the curve. So we had done something from this point forward that was really working. And then we began an intervention, and from that point forward, it seemed to actually make our data go in the wrong direction. And so if we were to aggregate this data, what it would look like is we would have a bar chart over here that would say that was our previous average, and then we would have a bar chart over here to say that was our secondary average. And our assumption would be, oh my God, our intervention worked. It was really effective. And so aggregate versus time-ordered data is critical for your grantees to understand. We often roll up our data too much, and that's the best way I can describe it. We take too much of it, combine it together, and take the average. And in doing that, what we do is we lose the ability to really understand what worked and what didn't work. Quality improvement is asking you not to roll up your data. It is asking you to look at it in as many time frequency as possible. So daily if possible, weekly, no less than monthly. Because the longer the amount of time before you look at your data, the less you really understand about your system when you are able to look at it. And so these are the two charts side by side. If we were looking at this data, if I gave you just this bar chart, you might think this intervention to decrease mortality was highly effective. You might give out some more money for it. You might spread it. You might want others to do it. But when you look at it over time, you realize this intervention was not at all effective. And you wouldn't spread it. You wouldn't continue it because it's not working. There we go. So what are some of the core basics of a run chart? It's displaying data over time. That means your x-axis is always time, as we talked about, day, month. We really don't want to see annual data at this point because it's just too much. And it really lets you communicate and understand the variation because systems are going to have variation. We talked about that when we talked about the system of profound knowledge. There's going to be variation in your data. Some days, weeks, or months will be higher than others. That doesn't mean that you've necessarily improved or lost improvement. It's just variation. They illustrate when you are really accomplishing things. So let's look at a few examples. So this is data over time, and looking at this data over the time, while we see some points that seem to be improvements, and so as we look at this, we see some points that seem promising. But in general, what we would say about this data is it's stagnant. It's a completely stagnant system. So if this was your grantee, what I would probably tell you is they didn't really accomplish much. They just maintained whatever their performance was over time. Now, if this was your grantee, I would say congratulations. Your grantee was incredibly strong. They both accomplished improvement, and they held the gains in that improvement. So their data points stayed up there. And if this was your grantee, I will say they did something fantastic, and then they lost the gains. And so whatever they were doing from this point to this point was really strong, but they didn't hold on to it. This is far too often the reality of quality improvement. And so your grantees will get specific amount of funding for a short period of time. They will change and improve the system, and then all of those changes will just kind of dive back off. They will go back to doing things the way they used to, the way they were comfortable. This won't be the focus anymore. And so as project officers, you're really looking for this in the data. Are we seeing that the hard work that paid off is not staying around? So just in summary, some of the key elements of data collection as it applies to quality improvement is, first and foremost, if you're not using the data, don't collect it. And so quality improvement is about using data. If you can't use that data, stop collecting it. The more frequent you're able to collect the data, the better. And you should be looking at the data often. And so your teams should be very intrigued by what their data is saying, in some regards, because they're not sure what to do next until they look at it. We need a package of measures, so we need some process measures, some outcome measures, and at least a balancing measure so that we can be looking across the system, not just at one or two key indicators. The method of collecting data should be reasonable and practical, and by all means, give data back to those who give it to you. And so there should be this very transparent loop of data sharing. So that was a lot about data, and it's not always everybody's favorite conversation. I'm going to just pause and see if we have any questions. I'm not seeing any in the chat box right now. Jean, have you seen any come through?
Yes.
Okay.
So the question is this: many clinical outcomes take more than 1 month to manifest. What are the dangers of looking at data too soon and making premature decisions?
Yeah, so that is a fantastic question. Yes, many clinical outcomes take a very long time to manifest. And so the purpose of looking at it before you truly expect outcome to be accomplished or improved is to understand what is the normal variation of the system before. And so there isn't a lot of baseline data collection in quality improvement. We often say baseline is wherever you are today. And so we don't say look back retrospectively a year. Baseline is wherever you are. And so if there's, say, a 6-month lag before you really expect some of these indicators to move, by beginning to collect it right away, it just gives you a sense of what is the current norm of the system, so that at that point where you really anticipate some improvement, some gains, you can see, did that truly happen? Did we shoot up some as we expected to, or did we really not? If you have follow-up questions to that, please feel free to continue to chat them in. That was a really great question.
Next question. What are some examples of strong outcome and process measures?
Okay, so we talked a little bit about a few examples that we've seen in the FOAs. And so some outcome measures that I think really matter and we're looking at right now are very driven by the patients that we're serving. And so I really liked this idea of measurement around, are we maybe doing earlier identification of patients who have dementia or related, Alzheimer's or related dementias. And so an outcome measure might be our ability to identify those people quicker. A process measure might be how often we're assessing our patients to see if they have Alzheimer's disease or related dementia. And so the difference in the system is that you're trying very hard to make sure everybody gets this new process, which is an assessment, and the outcome is more identification or potentially a quicker identification. So you're finding people sooner so that you're able to interact and do something about it faster. I just kind of gravitated to that particular issue. The core difference is that we spend far too much time on process measures. So how many students are trained, how many clinical preceptors we have, those are all really important. Another great outcome measure is the competence of those clinical preceptors. It also might be the length of time or duration that you have clinical preceptors, so your ability to kind of gain some longevity with your clinical preceptors is the outcome of a really hard process of making sure they're competent and able to take care and work with your students.
Next question. How do you take into account other factors and historical trends, seasonal differences, for example?
Yeah. So when you guys have great data questions. So when you have some confidence that there is historical, seasonal, or some specific time series difference in your data, that's the only time I really recommend the people that I advise to look back at their data. So let's say that you're expecting a seasonal difference around summer and you're just starting the project now. I would encourage the organizations that I work with to look back and see what was happening in that specific data a year ago so that they can get a sense of what is the normal variation in that system. Otherwise, a lot of times you don't have the opportunity to really look back at the seasonal trends, in which case I would say begin plotting your data over time so that you have some evidence and confidence of what those seasonal trends are, and then you can really account for them because, again, data collection and quality improvement is about learning, not judgment. So what you may be learning in your data collection over time is just what is the seasonal variation of the particular outcome that we're looking at or process that we're looking at. And sometimes we're not able to quantify that specifically, so the learning in your data collection might be the ability to now quantify, yeah, we expect services are going to drop off from June to August, but that we're going to have this real spike in September. What are we going to do about that?
Last question. How might a grantee use QI data in their proposed work?
So the grantee may use QI data primarily, as I was looking in the FOA, and I think actually as project officers, you're the best answer of this, but as I suspect is they're going to be using it in the evaluation component. And so I saw actually in many of the FOAs in the evaluation component, it said specifically how are you going to use rapid cycle quality improvement. So you're asking your grantees to use some of the measures, the indicators that you set forth. The difference in your grantees is that they were probably always going to be reporting those measures. You're just also encouraging them to look at them more frequently. So instead of waiting for, say, a quarterly or biannual report, you're asking them to look at them more frequently to say, how are they in tune with the work that you're doing? Are they showing you places where you should be improving the work that you're doing? One really good example is, if we're looking at say the number of people referred to a certain program. Now, they're going to aggregate that up and report it to you as a project officer. If they're looking at it, say weekly or monthly, whatever time frame makes sense, they might realize, geez, we're really not getting the referrals that we should be. And so we're going to miss the mark. We're going to miss the target. they can intervene on that very quickly so that when they roll it up and report it to you in a more aggregate fashion, they've intervened so that they can improve their system. They can get more referrals, get more people through, you know, whatever particular intervention it is, and therefore accomplish the outcome, which is improved care. I also hope that answered your question. It's kind of hard not to have a back and forth. Jean, if you have follow-up questions, let me know, and I can also make sure that my email address is available because I'm happy to kind of continue to answer these questions over email.
Okay. Okay, we're done with questions for now, so you can go on to the next section.
Okay, so let's jump into the final question in the model for improvement. What changes can we make that will result in improvement? So whenever I give this talk, it kind of frustrates people because this is where they want to spend most of their time. We all have ideas, and you know, I kind of like this cartoon because it feels like our world right now is an idea factory. There are a million good, promising, and somewhat bad ideas circulating our world constantly right now. But the truth is that your grantees and yourself as project officers have a lot of ideas about how we could improve care. So there is no real shortage for ideas. It is the process of how you try those ideas that makes quality improvement different. And so we use this process of PDSA, which we're going to go through in just a second, kind of the step-by-step components. But why do we use it? First and foremost, because it's fast. This is called rapid cycle quality improvement. It is fast. And in all honesty, most of our healthcare professionals have a relatively short attention span. So you can take an idea and try it out on, say, one older adult. You could try out an idea on one dental hygienist. It allows you to just try something very quickly with very low risk. And so we're always looking for the low risk, no harm option. Some ideas you can't try out in a clinical setting because you don't want to potentially risk harming, kind of as the quote goes, never harm the hair of the head of a child, but you want to choose those ideas with low risk, no harm, but most of the ideas that we're trying are those. We can try everything, and so the beauty of a PDSA is that no idea has to be chosen immediately, and we don't sit in a boardroom and make some decisions about that. We get out there and we choose ideas based on our experience. So it's based on experiential wisdom rather than just choosing an idea and we have no real experience of doing it. In doing that, we build confidence that our idea is actually working, and we learn how to adapt. So many ideas are actually fantastic, but it's the application of the idea that fails. And so we can learn how to adapt and change the process that supports our idea so that it can be effective. We're looking at evaluating the side effects. Are we robbing Peter to pay Paul? We can build momentum. So I've never worked in a healthcare system where I've walked in and said, okay, from this point forward, everybody's going to do things differently. And people have, stood up and cheered and clapped and screamed my name. There's a lot of resistance to change, any kind of change. And so using the PDSA process allows you to build that momentum and decrease resistance because you're not doing something, everybody's not doing something for every patient. You're just trying something on the next older adult who walks through the door. And in all honesty, this is one of the only ways you can make a real and true measurable improvement in the systems that we work in. So let's talk a little bit about a PDSA. So if we were to choose a specific idea, and we're going to walk through an example, but you choose an idea, the next step is to make a plan. So what questions do we have, and how are we going to try this idea? So what is the plan for trying this idea out? And the most critical point of your plan is a prediction. So quality improvement and the PDSA cycle is prediction-based testing. You're coming at this idea and you're saying very clearly, I think if I do X, Y is going to happen. That's your prediction, it's your hypothesis. And your plan is then giving you the opportunity to try out that idea to see if in fact Y happens. You need to be very specific, who's going to carry it out, how long is it going to happen, when and where is it going to happen. Step 2 is physically doing it. This is a step that is often forgotten. So we create a lot of plans in our work environment. We don't always do them. And so you carry out your new idea. You may document the problems, unexpected observations. You begin to collect some data at this point, but it's very observational data. So how did it go as I tried that out? You complete and study what you learned from that. So if you then take a step back and say, well, this was my prediction. I did it. This is what truly happened. Where is there discrepancy there? So did what I expect happen? If it didn't, why? What might I do differently to get my expected result? And that's where you kind of make some decisions about acting. How are we going, if I were to do this again, what would I do differently? And what might the next cycle look like? And so this is actually something most of us do in our day-to-day life. And so I am the mother of a 2-year-old, and I do this every day. So we try out a new idea, we see if it actually worked. In the evening, I kind of study whether or not it was effective, and then we come up with a new plan for the day. I'm sure you guys do this. There's great examples about, how to quickly get to work on time. But again, we're working through each of these steps with some hypothesis about how things are going to be better. Now, in contrast, we often try ideas by saying, okay, now we are going to, I'm going to kind of keep with this geriatric dementia assessment. We're going to assess all patients who might be at risk, and we just do it. And then what happens in 6 months is that we realize, well, none of the nurses are actually really doing the assessment. Nobody could find the assessment. We didn't have a place to document it in the EHR. A whole series of things happen. But the end result is that nobody was actually assessed for Alzheimer's disease or related dementia. Now, did you accomplish what you set forth? No, you didn't. The difference in the nuance in a PDSA cycle is that it allows you to say, okay, Nurse Jackie, you're going to see, Mrs. Smith in a few hours. Could you just do this assessment on her and let me know how it goes? So as we continue to think about the PDSA, I cannot underestimate how important a prediction is required in your plan. And the reason why that plan needs a prediction is because a lot of times what we are doing is tasks, not tests. And there's a kind of nuance in those. So handing out a brochure is a task. A test might be, if I hand out this brochure, will the families have more questions when the provider walks in the room? Now that's a test that has a prediction. You expect somebody to behave differently because of what you're doing. I can't seem to get, there we go. A lot of times in doing rapid cycle quality improvement, we do it for a bit too long, and so we test ideas for a really long amount of time. And the truth is that you learned a lot in, say, the first few days, maybe the first week of trying a new idea. So as you're doing it, as you're carrying out that plan, one of the mantras of quality improvement is cut it in half and cut it in half again. So if you want to test an idea for a month, cut it in half, that's 2 weeks, and cut it in half again, that's a week. Try it out for a week and see how it goes. There are nuances to these systems. So I do a lot of work in the newborn hearing screening realm, which I know is a little outside of your realm at HRSA. But, and that's a really rare event, so they have to test for a little bit longer. You're looking to set up the nuances of your tests so that you can get just enough evidence to make a decision about what you should do differently. The length of time is not about doing it for a very long time. It's about getting enough evidence to make a decision. And that's where the study is so strong. As I said, the study part is the point at which many people forget to truly use quality improvement, but we cannot do this kind of iterative cycle of quality improvement without it, because inevitably something's going to go wrong with your idea. And all of us have experienced this. So we've tried a new idea. If we tried on a really large scale, it may have failed in a very large way. If we tried on a very small scale, it may have failed in a very small, minor way. But that opportunity to kind of look back and say, whether this idea completely failed or there just was kind of points in the system that you got some unexpected results, what happened that was different than I thought it would, so that you can make informed, educated, very smart decisions in the end. And the smart decisions are about, well, how could I do this just a little bit differently. So let's talk about, there's an example around assessing preceptor competency. And again, we've talked through many of these examples, so you may want to come up with a way to assess preceptor competency. You may choose one of the evidence-based tools that are out there, and you're doing site visits with your preceptor, so you use the tool with just one preceptor. And in doing that, if you're assessing her competency with this very specific tool, as you're doing it, you realize this is actually taking a really long time, and your preceptor hasn't allotted this amount of time for your meeting with them. And so your grantee may say, geez, well, this tool seems fantastic, but when I tried to use it, the preceptor didn't have enough time, we weren't able to finish it. And so what would the study phase of that be? Well, the study phase may say, okay, well, this takes longer than I expected. I need to let the preceptors know when I'm coming out to do my site visits, I need extra time to complete this test. So the site visit's going to be 2 hours instead of an hour. And then you would act on that. You would do it again in the next preceptor that you had to do a site visit with. That's exactly how you would try it out the next go-round. And so while it feels kind of small and manageable, what you're looking for is to ramp up so that you're confident that what you're doing with all of your preceptors is strong and effective. So it's improving that belief that the idea is good and that people are better because of it. And it is improving the process to make sure everybody experiences this idea. So ideas could be great, but if you don't do them, it doesn't matter. And again, you're looking to accomplish your aim. And so while we start very small on PDSAs, these balls continue to roll up and your scope gets bigger and bigger and bigger. So you start small because your confidence is relatively low. It's just it's a theory, it's an idea. You end big so that all preceptors are experiencing this specific competency evaluation, and you're able to do it and do it well. Sometimes people get really frustrated. Well, yeah, I could test an idea with one family or with one older adult or in one primary care practice, but who cares? How are we going to really accomplish the outcome? Well, it's part of a trajectory. It's just it's flipping it on its head a little bit, where you start very small so that you can get there quicker. The model for improvement is simple and balanced, and I say this because sometimes we over-focus on testing or changing ideas, but we don't have an aim statement, so we don't really know what we're trying to accomplish. And when you don't know what you're trying to accomplish, you can choose ideas out of the air. It's almost like shooting darts in the dark. It doesn't really matter because you don't know where you're going. Or you can try a ton of ideas and never measure the impact of any of them, so you have no sense of if your hard work worked. Or you may have just added a lot of complexity to your daily life that's not actually improving outcomes. It is important that we continue and your grantees continue to think of all three of these questions as they move their projects forward, so that at the end of your specific FOA timeframe, they can have accomplished what it is that you asked them to and gave them the funding to do. I know we don't have a question slide right here, but Jean, I'm going to pause and see if there's any questions before we talk about next steps.
So, Amanda, yes, there actually are. There's one question and there's one comment. So I'll start with the question. Have you worked with healthcare facilities that used PDSA to consider patient outcomes? And what are some of the outcomes that were considered?
Yeah, so I've worked with hundreds of healthcare organizations to improve patient outcomes. One specific area that we've spent a lot of time on is sickle cell disease. So improving the care that patients who have sickle cell disease receive, and specifically the care they receive when they have kind of an acute pain crisis. And so without getting into the weeds of sickle cell disease, pain crises are pretty common in sickle cell disease. And the care that a hospital or emergency department provides that patient with sickle cell disease needs to be incredibly quick to mitigate that pain and mitigate it quickly, and to deal with the chance of them getting kind of increasingly sick. So if that pain is not dealt with quickly, the chances that they're going to get much sicker are much higher. And so we worked with a lot of healthcare systems. This was actually a HRSA-funded project to improve care for patients with sickle cell disease in the emergency room and And what we found is an incredible increase in, well, decrease in the amount of time that it took to get patients care. So when we began the project, it was over 60 minutes that it took before a patient got a pain medication. By the end of the project, it was much closer to 30 minutes. We also found an incredible decrease in the admission rate, and so because they were able to decrease, they were giving that first pain medication quicker, the patients were able to kind of rebound a little bit quicker and didn't have to be admitted to the hospital. And so those were some kind of very specific clinical outcomes that were accomplished by just this iterative cycle of, well, how would we get a pain medication to a patient faster? What are some ideas we could try? Could we have the patient call us when they were on their way to the emergency room? Could we have the hematologist be in charge of making sure we knew what the pain regimen was, and we were able to really deal with that? And so there was many different ideas, and we worked with 15 sites across the country. They all tried a different idea, but their results all reflected what mattered to their system, so that we were able to both increase that process measure, which was the time to first pain medication, and increase some of the outcomes, which was not being admitted or readmitted to the hospital.
Amanda, we have another question. What are some outcomes to consider for educational programs?
Yeah, so outcomes for educational programs are a little bit different, but I think to me this is a great conversation and kind of builds into what we're going to say the next steps are. So outcomes for educational programs, and in looking at most of the FOAs, there was both an educational component and then there was a clinical component. So kind of the ability to merge educational programs with clinical sites and community-based setups. And so I think there are ideas that you can be trying so that your students are kind of engaged in those clinical settings in a much more proactive and meaningful way for the student, and you can measure some of those outcomes around kind of student experience in their clinical settings. There are also certain things in the educational world that are just not sensitive to quality improvement, and so I do acknowledge that there will be components of the work of your grantees that will be highly aligned with quality improvement. Changing the curriculum of a particular program is probably a farther stretch to being aligned to quality improvement. And so I don't speak for any of anybody who put together the FOAs. That's just my personal take on how I would say this applies. But quality improvement doesn't apply to everything. It applies to many things. But big things like kind of changing curriculum, those are somewhat difficult to test small ideas on. Jean, would you add anything to that?
No, I think that's right. And the comment is one that suggests that everyone who's participating in the call should review progress reports of grantees to find best practices and then collect best practices to share with grantees on technical assistance calls.
Yeah. Yeah, you know, you're really looking for those places where quality improvement matters so that you can kind of push your grantees to apply it and apply it a little bit more strongly, because it's not intuitive to some people. But yeah, as a project officer, you have this innate opportunity to really find the ideas that work, that are strongest, and give them back to the rest of your grantees so that you can help them accomplish improved results as well. So you're kind of, in many ways, serving as the gatekeeper of sharing those really great ideas. Jean, I see that we're getting a little close to the top of the hour, so I did just want to quickly talk about our next steps. And so while we just talked about the foundational knowledge of what is rapid cycle quality improvement, how might grantees be applying it, this is step one of a multiple-step process, and step two will be doing a workshop, a half-day workshop on June 23rd with project officers. And we're really going to dive into the weeds there of how do you apply this, what is it, what does it mean for your role as a project officer, how can you get kind of continue to leverage this idea of sharing best practice ideas that are coming out of one grantee with another grantee, how can we continue to leverage that sharing of information across your other grantees, and how can you apply this so that as you're looking at progress reports and as you're having conversations with your grantees, you can have this kind of lens and coaching model of quality improvement in the back of your mind. So that's step two of this process. Jean, anything else you'd add?
Nope, I think that covers it.
All right. As David said, please take a moment to go and answer the survey. My understanding is that when the webinar closes, this website will automatically open up so that you're able to do it right away. Thank you so much for your time today. I really appreciate it. If you continue to have questions, we'll make sure that you get my email address after this, and I'm happy to answer them or continue the conversation. Have a great day, everybody.
Thank you, Amanda. It was a wonderful presentation, and thank you, Jean, for moderating the event.
And thank you out there for attending our webinar. Just to let you know, we will be posting our slides shortly to our website. So if you want to download them, check back very quickly at healthworkforceta.org. We hope to see you again in the future. Thank you, and have a good day.